association with neoplasia, causes of testicular inflammation, pathophysiology of torsion, testicular tumors, especially the seminoma and non-seminomatous tumors, and then the sex cord gonadal stroma. Okay, so because you haven't had your testicular histology yet, so these are the three main structures in the histology of the testes are the seminiferous tubules with the germ cells within the tubules, and then there's also the Sertoli cells. Yeah, so the germ cells and the Sertoli cells within the seminiferous tubules, and then you also have these Leydig cells. So the Leydig cells are producing testosterone. And these are the components of the tumors. Yeah? The germ cells will form the germ cell tumors, and then you have the Sertoli cells can also form its own tumor, and then the Leydig cells can also form its own tumor. Yeah? The difference is the things that they produce are different. Sertoli cells, Leydig cells, they produce testosterone, but when they become tumors, they can produce either testosterone or estrogen. So it became haywire. So that's the pathology that we're going to see. The non-neoplastic component is we see cryptorchidism. So what is cryptorchidism? Is undescended testis or failure of the testis to descend to the scrotum, and its epidemiology: 1% of 1-year-old boys, so that's quite high. But during neonatal examination, the examination of the testis, whether the testis has descended or not in the scrotum, is very important. So we see this case. 19-year-old man comes to the physician and there's no left testis palpable in the scrotum. The patient is healthy. So what's the diagnosis? The diagnosis is the failure of descent of the testis to the scrotum, that is cryptorchidism. So which one do you think is undescended testis? The one on your right of the screen or the left of the screen?
Yes. Yes. Right.
The right, yeah. Why do you say that? Because there is. What's the change that you see here?
Atrophy.
Yes, atrophy. Yeah? So we see atrophy because but some of the cells are not proliferating, especially the germ cells. They are not maturing because the maturation of the germ cells needs a certain temperature that is below the body temperature. So there's going to be atrophy of the testes. So what's the most common location for undescended testes? Inguinal. So, and the risk or complications associated with this condition, there's quite a few. There's infertility. There's also risk to develop germ cell tumors, trauma, and inguinal hernia. Right? Okay, so non-neoplastic causes of testicular swelling. There's inflammation, inflammation, tuberculosis, or the sexually transmitted disease. Okay, and then you have varicocele, hydrocele, and tumor. Well, not tumors. It's non-neoplastic. So describe the causes of testicular inflammation. Then you have the sexually transmitted diseases if you certain age, and other causes, other pathogens. after a different age. So we will see that later. So how do you differentiate? Can you differentiate the clinical presentation of inflammatory testicular swelling with neoplastic swelling? So there are, usually inflammatory testicular swelling is painful. And neoplastic swelling, the most common presentation is painless, although they can come in with painful swelling. Okay, so but inflammatory, there is usually painful swelling, but the rule is usually you try to rule out testicular tumor first if there is testicular swelling. So all testicular swelling is neoplastic until proven otherwise. Just think about it that way. Okay, so you have to think about the tumor, rule out the tumor first, and then you start to think of other differential diagnosis such as swelling, but the inflammation, varicocele, hydrocele, and things like that. So you do other tests to confirm it. Okay, so we go to case 2. So this man presents with scrotal pain with urethral discharge and fever, and on further questioning, he reports 2 new sexual partners, and examination showed swollen right scrotum. It's painful to touch. Trend sign is present. So elevation of the scrotum decreases the pain. So this test is to differentiate epididymitis with torsion. So torsion, the elevation of the scrotum does not decrease the pain. So most likely diagnosis for this is epididymitis. So the most likely pathogen in this case, because there is a history of sexual 2 new sexual partners, so we think of sexually transmitted disease. And then he is less than 35 years old. So we think of Neisseria and chlamydia. Whereas if the patient is more than 35 years old, you think of UTI, so such as E. coli and Pseudomonas aeruginosa. Okay. So stop me if you have any questions, right? 25-year-old, previously healthy man, suddenly developed severe pain in the scrotum, and then there's tenderness on the enlarged right testis. The gross appearance is shown here. So it is very, well, it's engorged. It is the appearance is very red. Okay, so this is what we see. If we see this, I mean, you've seen normal looking testis is like that, yeah, and if you see it like this, yeah, it's very red, it's very engorged, so you think of some hemorrhagic infarction, twisting of the testis around its blood supply. Okay, so this is torsion. So this is testicular torsion. This is an important urological emergency. So if you see this, then you have to send the patient straight away to the hospital. So because it can be salvaged if it is done early, if intervention is done early. So 3 other differential diagnoses of painful testes. So think of epididymitis, and think of some neoplastic diseases, and also varicocele, yeah, that can also present with pain. Okay, so pathophysiology, we've said just now, is twisting of the testis around its blood supply. A 15-year-old boy presents with pain in the scrotal area. He denies any rash or inciting trauma. So, and then on examination, there is a bag of worms observed at the left scrotum, which is visible when he stands and disappears when he lies down. The scrotum does not trans-illuminate with light. So if you see this, this is a common terminology that is used for this disease, yeah, for this condition. So this is a varicocele. The pathogenesis, we've talked about it yesterday when we talked about renal cell carcinoma. So if there is a blockage of the testicular vein, when it drains into the left renal vein, then there's going to be backlog of blood in the testicular vein, and then it will cause engorgement, enlargement of the pampiniform plexus, the venous plexus around the testis, and that will cause this bag of worms appearance. Okay, so this condition is more likely to affect the left side because of the anatomical drainage of the left testicular vein into the left renal vein, whereas in the right side, the right testicular vein drains directly into the inferior vena cava. So complications of this condition, you can have well, the infertility, you can have failure of the testicular growth and infertility. Okay. Okay, trans-illumination test is where you shine a light at the scrotum, and so if the light pass through, then it's positive. You can it indicates that there is a fluid around the testis. So this is a case of hydrocele. Is the finding of a lump in the genital area. So there is tense and non-tender mass in the scrotum. Trans-illumination test is positive. So this is hydrocele, and the pathogenesis is because of the failure of the closure of the tunica vaginalis. So you have accumulation of fluid between the spaces, between the layers of the tunica vaginalis. Okay, so the complication includes inguinal hernia and infection. So these are the common causes of testicular swelling, non-neoplastic ones. So varicocele, hydrocele, testicular torsion, epididymitis. Yeah. So these are the common ones, the non-neoplastic ones. So now we go to the neoplastic causes of testicular swelling. 30-year-old man presents with hard painless mass arising from the testis, the right testis, and lab investigation for alpha fetoprotein, beta HCG, and LDH was done. Radical inguinal orchidectomy was done. Diagnosis of seminoma was made, and the patient underwent radiotherapy post-operatively. Okay, so this patient has had seminoma. So, and the finding is he came to the clinic to see and then presenting with painless mass, and the doctor did lab investigation, but you see that there's no biopsy done. So this is the normal procedure. No, we don't do biopsy on testicular swelling, because if you do biopsy on testicular swelling, there is a risk for dissemination of the cancer cells. So that would make it more difficult to remove the tumor if you want to do the total removal of the testis. So we don't do biopsy. The doctor will immediately ask the patient to be the testis to be removed. Okay, germ cell tumors are tumors that derive from the germ cells. Yeah, the germ cells are. Am I losing the picture?
Yes.
Okay.
Yes.
Yes.
All right. Is it back on?
Yep.
Okay. Right. Okay. So germ cells, we have germ cells in the ovaries, we have germ cells in the testes, and in the testes they differentiate into spermatozoas, and germ cells in the ovaries, they form the ovum. Okay, so we have these germ cells. They can produce tumors. The tumors that they can produce are seminomas, choriocarcinomas, embryonal carcinomas, teratomas, and yolk sac tumor. There are 5 tumors that can be derived from germ cell tumors. And there are some tumors, they mixed, yeah, there are mixed types of tumors. So what are the risk factors for germ cell tumors? So we've talked about one of it just now in the previous section. There's the cryptorchidism. The significance of cryptorchidism is there's a percentage that would progress to germ cell tumors. Yeah? About 1 in 500 men will get cancer of the testes, and the most common type is seminoma. Okay. The other risk factors,
Tourism.
yep. There's a testicular dysgenesis syndrome, where you have Klinefelter. We either have Klinefelter syndrome, testicular feminization, androgen insensitivity syndrome. So, and then genetics, isochromosome 12. Okay. So these are the risk factors for germ cell tumors. Yeah. So the more important ones is cryptorchidism, because it increases the risk to get germ cell tumors. Common clinical presentation of testicular neoplasia. This is one. Yeah, the presence of hard, painless mass, and then some can present with painful mass, but the most common one is painless mass. Some patients they present with metastasis. Okay. So tumor markers, we have alpha fetoprotein, beta HCG, and LDH. Yeah. And the significance of the lab investigation. Seminomas, what do you expect the levels of the tumor markers in this case? What do you expect the alpha fetoprotein level to be? You expect it to be high or normal?
Yeah.
Sorry? In the case of seminoma,
High.
okay.
False.
Sorry?
False.
False. Beta HCG, we expect it to be high in seminomas?
No.
Might be normal.
Normal. Okay. So you don't expect so you don't expect the levels of alpha fetoprotein or HCG to be high in this case, yeah? Because alpha fetoprotein is usually produced by the yolk sac tumor, and HCG is usually produced by the choriocarcinoma. Okay, and LDH, on the other hand, just shows the level shows the tumor bulk. The bigger the tumor, the higher the level of LDH. Yeah, so it's used to monitor the tumor bulk, and it's also used to monitor recurrence. So let's say after removal of the testis, so you expect the LDH level to drop, but after some time, after monitoring, after 1 or 2 years, then you notice that LDH level is increasing, so there is a risk for that patient to develop metastasis. Yeah, because LDH it's not supposed to increase after removal of the tumor. Okay. So we'll go through this in the what do you call the section and practical section. Okay, so there's germ cell neoplasia in situ. Okay, I still call it intratubular germ cell neoplasia here. Intratubular germ cell neoplasia is the old term, so now it's germ cell neoplasia in situ. So the significance of finding this is if you when we have patients who had undecided testis, and then that is sent to the lab, and if we find this intratubular germ cell neoplasia in the cryptorchid testis, then the patient has a 50% chance to develop germ cell tumor within 5 years. Okay, so that is the significance of finding germ cell neoplasia in situ. So this is a pre-malignant lesion. So the patient has a risk to develop germ cell tumors. So what's the expected response of seminoma to radiotherapy?
Respond well.
They respond very well. Yeah. The seminoma has been treated with radiotherapy since the 1930s. Yeah. So it is a very there's very good documentation of seminoma response to radiotherapy for almost 100 years already. So the prognosis of seminoma,
Good.
yeah.
Excellent.
Yeah, so it's excellent. So they say that this is one of the tumor, if it has not metastasized, it is one of the tumor that is that has the best cure rate. Yeah. So as long as it has not metastasized. Non-seminomatous germ cell tumor, we've talked about it just now. Yolk sac tumor, teratoma, choriocarcinoma, and embryonal carcinoma. So the difference is these are the things that are different between seminoma and non-seminomatous germ cell tumor. Response to radiotherapy, we talked just now. Seminoma has an excellent response to radiotherapy versus the non-seminomatous germ cell tumor. Yeah, they have a poorer response. Metastasis, seminoma tend to be localized, Non-seminomatous germ cell tumor tend to metastasize early, and prognosis, seminoma has an excellent prognosis versus a poorer prognosis for non-seminomatous germ cell tumor. Okay, another testicular swelling, but note the age. If it's a young child, think about yolk sac tumor. Okay, so yolk sac tumor tends to be in a younger age group, whereas the others too, they tend to be about 20s and to 30s. Okay, so this particularly, you see the age group, testicular swelling, and then you see the alpha fetoprotein level is elevated. So think of what do you call yolk sac tumor. So this is a boy, bukan man. So most likely diagnosis because of the age, and testicular swelling, and also the serum alpha fetoprotein level is elevated. It is yolk sac tumor. Okay. Okay, so we'll look at it later. So this is embryonal carcinoma. Okay, so we've talked about prognosis tadi juga ya. The other thing about ni, if you see a seminoma versus non-seminomatous germ cell tumor, the non-seminomatous germ cell tumor tends to be necrotic and hemorrhagic, just like this one. Okay, because it's more aggressive. Okay, so there's a lot more invasion to blood vessels. And then the growth is very fast. So that's the aggressiveness of the non-seminomatous germ cell tumor is higher. Okay, 25-year-old man with a testicular swelling, and then they did lymph node dissection. So within the lymph node pun we see necrosis and hemorrhage, and then you have these cuboidal cells intermingled with large eosinophilic syncytial cells containing multiple dark pleomorphic nuclei. Okay, so if you see this neoplasm that is necrotic and hemorrhagic, would you think of seminoma or non-seminomatous germ cell tumor? Non-seminomatous, yeah. And then you see lymph node metastasis, yeah. So it's more likely to be non-seminomatous juga, because think about we talked just now, seminoma, they are usually localized, kan? And then you see the microscopic feature. Yang lain tu semua sama. This one has pain because it's very aggressive. So the microscopic feature, you see syncytial cells, means that the cells are merged together. Yeah, it's multinucleated cells. There's multiple dark pleomorphic nuclei, so it's multinucleated. So the only thing that shows this kind of feature is the choriocarcinoma that has syncytio trophoblasts. Yeah. So there's syncytio trophoblasts. So this sentence, it describes that. So you expect the tumor to be very aggressive, hemorrhagic. Okay, and there's these cells, the multinucleated cells, are the syncytio trophoblasts. Okay, so this is a very, very aggressive tumor. Yeah. So the tissue is similar to the placenta tissue. So you just imagine, even in the normal placenta, the placenta, one of the things that it does is it invades into, it has to invade through the endometrium, yeah, because it has to be stuck there. So in a normal, even in normal pregnancies, some of this placenta can invade through and through the uterus. Okay, because of the ability of these cells are quite aggressive, even in a normal pregnancy. Just imagine that if it becomes malignant, it can spread easily. It can invade through any tissue. So this is one of the most aggressive tumor there is, choriocarcinoma. So the cell of origin is the trophoblastic cells that can be cytotrophoblasts or syncytiotrophoblasts. We usually see a mixture of those, and the tumor marker that is associated with this is beta-HCG. Just like in a normal pregnancy, you see the beta-HCG level is increased. So in choriocarcinoma, you expect the beta-HCG to be elevated. Okay. Now, another case of testicular swelling, but this time microscopic examination shows areas of mature cartilage, keratinizing squamous epithelium, and colonic glandular epithelium. Okay, so this is what tumor? Anybody?
Teratoma.
Teratoma. Okay, so teratoma is derived from the 3 germ cell lines. Yeah, so there's mesoderm. You see the cartilage, ectoderm, the squamous epithelium, and endoderm, the colonic glandular epithelium. So this is derived from the 3 germ cell lines: the mesoderm, endoderm, and the ectoderm. So the lab findings here include elevated HCG and alpha fetoprotein. So this is a 30-year-old man. Most likely diagnosis you see here is the mature, teratoma. Okay, teratoma. And the gross and histologic feature, you see these features. So you have the cartilage, you have the squamous epithelium, and then you have the glandular epithelium. And then grossly, we see cystic solid tumor. So despite the appearance of the cells in the tumor, the cells were mature. Sometimes we have immature cells, immature neuroepithelial cells, so we call it immature teratoma. So that is malignant. Okay, but the surgeon tells the patient that he probably has a malignant testicular tumor. Why is that? Anyone has any idea?
Because 30-year-old man.
Yep.
It's adult.
Okay, so that's okay. So we say that children mostly are benign. The teratoma in children are mostly benign, but post-pubertal teratoma are considered malignant and has a potential to metastasize. Another reason, anybody? That's good.
Can metastasis?
The clue is in the stem. Do you expect the lab findings to show elevated HCG and alpha fetoprotein in teratoma?
No?
No. So if you have that finding, what is the possibility?
Mixed tumor.
Mixed tumor. Yeah. So that's the possibility that this tumor is a mixed tumor. So you can guess that the mixture would be of what tumor?
Yolk sac and chorionic carcinoma.
Yeah, choriocarcinoma. Yes, good. Okay. Okay, now we go to the last one. So this is a different type of tumor. It's not the germ cell tumor. This is the sex cord tumors. So 25-year-old with painless mass, AFP and HCG is normal, testosterone level is elevated. And ochiectomy is done. The tumor shows homogeneous yellowish surface. Microscopically, you see cells that are eosinophilic with Reinke crystals. These are Reinke crystals. Okay. Diagnosis of Leydig cell tumor was made. Yeah, so this is a sex cord tumor derived from the sex cord cells, such as the Sertoli cells or the Leydig cells in males, and in females we have the granulosa cells and theca cells. Okay, so so those are the tumors. The Leydig cells can form Leydig cell tumor, Sertoli cell tumor. The granulosa cells can form the granulosa cell tumor. The common clinical presentation of sex cord tumors, because they can produce hormones. Yeah. But the hormones that they can produce can be vast. It can be either Leydig cells can produce either testosterone or estrogen, for that matter. So you can have precocious puberty in these patients. You can have virilization, or you can have feminization in a man, yeah, because of estrogen. Okay, so identify the tumor markers. The tumor markers in this case is the testosterone, yeah, but they did also AFP and HCG here. Okay, so the lab investigation, the testosterone level is increased because of the production of testosterone by the Leydig cell tumor. So there's a big difference between sex cord tumor and germ cell tumor. Germ cell tumors, they are mostly malignant, okay, except for teratoma in a young child, okay, that can be benign. But sex cord tumors, they are mostly benign. They are mostly benign. Clinical presentation, sex cord tumors, because of the ability to produce the sex hormones, so they can cause precocious puberty, they can cause gynecomastia, they can cause virilization of okay, so all the sexual characteristics is produced by the sex hormones. Okay, so why is the cut surface yellow?
Because of steroid hormone from production of cholesterol.
Yeah. Okay. Good. Okay. So because it's from cholesterol, so it's a steroid hormone. Okay. Any questions? We quickly go to Kahoot just to see.